the current chairperson of the sleep subsection. Dr. Manveer Bhatia, the convener, shall be joining soon. Today we have an interesting agenda. We have two gifted speakers from within the subsection, Dr. Datta Nadgir and Dr. Gino Johnson. The aim and ambition of the subsection is to promote understanding, knowledge, perspective, and enthusiasm for all things sleep related, uh, linked to neurology in its very fascinating different nuances. So we're going to have two cases being discussed today, one by Dr. Datta Nadke and the other one by Dr. Gino Johnson. And I'm pretty certain both these accomplished members of our subsection have an interesting perspective on how sleep and neurological dysfunction are very closely intertwined. Dr. Manveer Bhatia shall be joining us soon. She had messaged me earlier in the evening today that she is held up with some other professional commitment, but she will join in soon for the discussion at the end. And I can see from the attendee list that we currently have about 34 participants on board. And therefore, without much ado, it is my great pleasure to welcome both our honorable speakers today, Dr. Datta Nadgir and Dr. Gino Johnson. Welcome. Um, and I'm happy to request Dr. Datta to share his screen and um, start his presentation.
Yeah.
Dr. Datta Nadgir runs a sleep unit at Hubli. Datta, correct me if I'm wrong.
Yeah.
He has a busy neurology practice, and being an astute clinician, he is deeply interested in the intricate nuances with which neurological dysfunction and sleep aberrations are connected. He is a certified uh, sleep specialist. He is certified in international sleep searches by the World Sleep Society. And today he's going to talk to us about an interesting patient that he saw in the recent past. So, Dr. Datta, the stage is all yours.
Yeah. Good evening, everyone. Am I audible?
Yes, you are, loud and clear.
Yeah. I would like to present an interesting case who presented to our clinic with refractory migraine or labeled as a refractory migraine. And this is a 25-year-old software engineer from Bangalore. He presented to us with a recurrent early morning occipital headache, which is going on for many months, which was not responding to multiple anti-migraine drugs, including the calcium channel blockers, topiramate, sodium valproate, which were tried in sequence and also in different combination. And there was a history of recurrent cold um, and being diagnosed as allergic rhinitis. So this young man presenting with recurrent early morning headache ongoing for months and being labeled as migraine and carrying a prescription of multiple anti-epileptics along with the treatment for acute episodes of headache. And why I'm presenting this case is a young non-obese patient labeled as refractory migraine. The real driver was almost missed, and this diagnosis only emerged following a lab abnormality and not the headache itself. So what happened was his routine investigations, routine investigations were normal. His MRI brain done to rule out secondary headache was normal. Routine blood biochemistry was normal. The full blood count was normal, except for one abnormality, that is hemoglobin was 17.7 gram per deciliter. So mild secondary erythrocytosis in a 25-year-old person was unexplained at this point of time. So he was worked up for polycythemia, including the routine investigations and the JAK2 mutation, which was negative. So primary polycythemia was excluded. So we considered could be a secondary cause more likely, and the workup for his polycythemia was continued. So what during examination, what we found was interesting fact was this patient had a um, retognathia. retognathia, posteriorly set mandible on a profile examination, and also oral examination showed uh, reduced posterior airway space. On specific questioning whether patient had a snoring, he said he used to get snoring, but he attributed it to the recurrent cold and a diagnosis of allergic rhinitis. So he never volunteered that, and his neurological examination was unremarkable. So the retognathia, JAK2 negative, JAK2 negative erythrocytosis, nocturnal snoring raised a suspicion about an anatomical driven obstructive sleep apnea phenotype. And the first polysomnography was ordered. If you see in this polysomnography report, sleep FSG was quite adequate with a markedly fragmented sleep and with an AHI of 36.8, which characterizes the severe obstructive sleep apnea, which was hypopnea predominant, with significant oxygen desaturation index of 19.7. The minimum SpO2 was not going down below 90, and the time with SpO2 90%, that is T90, was not very significant. So it indicating it was shallow and high frequency dips of oxygen saturation, and also had a significant snoring index. So we labeled him as an severe obstructive sleep apnea, severe snoring, and then um, so this case with a working synthesis of a patient presenting with severe obstructive retognathia producing severe obstructive sleep apnea, producing chronic intermittent hypoxia, and which in turn producing secondary headache and secondary erythrocytosis. So this was a working hypothesis of this patient presenting with refractory headache or refractory migraine, found to have the polycythemia, and then we found to have an obstructive sleep apnea, and the cause of it is anatomical substrate erosion retognathia. So how do you treat this case further? Once we have achieved this diagnosis, we thought the obstructive sleep apnea, if you correct obstructive sleep apnea, most of his symptoms or episodes of migraine should disappear. So what we did first was the trial of oral advancement prosthesis. So because the retognathia is directly treatable anatomical driver, mandibular advancement should enlarge the retroglossal airway, and this is usually the reversible first non-surgical step before coming to a definite skeletal surgery. And what happened, this was a prosthesis which was used, this actually was done by a maxillofacial surgeon, and actually it was the measurements were taken, and it was devised as per the patient's requirement. What happened was his headache frequency became significantly less, though the episodes persisted, but the frequency intensity came down significantly. His hemoglobin fell from 17.7 to 16 while using the device over a period of 4 to 6 months. But the important finding was here, he had a very poor long-term comfort. He was complaining a lot of oral pain, discomfort. So the to use continuously was a problematic for him. So this is in polysomnography, which was done when he was using the oral advancement, oral appliance, mandibular advancement device. Though this study is a level 3 study which was done. The initial study was level 1 and this was a level 3. So we cannot directly compare, but the respiratory and oximetry channels we can compare. And if you see in this, all the respiratory and oximetry channels were significantly improved. AHI, oxygen desaturation index, saturation, and then the T90 was remained the same, but the snoring and other parameters were significantly improved. So what happened to the hemoglobin? From 17.7 it came down to 16. However, he had a persistent headache with a long-term uncomfortable with the long-term use of oral appliance. So what should we do next? If you see in this slide, the oxygen desaturation fell by almost 85%, and the saturation increased by about 2%, but the T90 changed. So here, both the studies, T90 stayed near zero at both the studies. So these saturations were quite frequent and shallow. They were not deep. So the hypoxic stimulus tracks with the ODI, means oxygen desaturation index, and not the T90. So with this patient, what is the next how we approached this patient was because he was unable to use it for longer period of time and the headache persisted, and HB was not came down significantly. It was up by 1.7 gram percentage. So what we did was we thought we gave him option of a definitive surgery for him. Despite mild recovery in the hemoglobin and PSG findings, and because of poor long-term tolerability, we asked him to. We explored the possibility of surgery, and this corrective surgery, which was done for retognathia, was mandibular advancement surgery, that is BSSO, that is bilateral split sagittal osteotomy. If you see in this photograph, this was a pre-op and this is a post-op. The retognathia which was there was significantly improved. I have an Excel which I will show it in subsequent slides. And this is what happened. Not apart from the appearance of a retognathia, what the this is what is done with the bilateral sagittal split osteotomy, where they split open the mandible and they advance the lower part of the mandible, and then it is fixed with the platinum plate and the screw. So these are the X-rays. If you see this is a pre-op X-ray where there is a significant retognathia, and this is a post-op X-ray where there is mandible advancement was done. And this is also post-op X-ray where the fixation plates was done on right and the left side. And if you see the retroglossal airway, significant improvement in the retroglossal airway compared to the retroglossal airway, which was significantly narrowed in the preoperative X-ray. So this patient, there was a significant resolution of symptoms after the corrective surgery. Headache almost completely disappeared, snoring has completely stopped, and hemoglobin dropped down to 15 gram per deciliter. Stepwise normalization. Of course, now we will be doing a next polysomnography in the subsequent visit. That would really confirm. But the outcome was completely based on the complete resolution of symptoms of headache, snoring, and normalization of hemoglobin. So subsequently, when we do the sleep study, we'll get all the cardiorespiratory parameters improvement. So the questions here are how this obstructive sleep apnea headaches are related, how the obstructive sleep apnea and migraine are related in our patient, how to differentiate these two different obstructive sleep apnea phenotypes, and how this obstructive sleep apnea producing secondary erythrocytosis or polycythemia, and how this erythrocytosis is responsible for the headache. So the different mechanisms how the obstructive sleep apnea produces headache have multiple mechanisms, starting from hypoxia, hypercapnia, producing the dilating the pain sensitive cerebral vessels. Fragmentation of sleep and frequent arousals can lower the pain threshold and also upregulate the pain perception. Intracranial pressure swings, increase intrathoracic pressure, exaggerated negative intrathoracic pressure, impairing the venous return and raising the ICP. Autonomic and sympathetic surges also sensitize the vascular pain pathways. And of course, the oxidative stress and neuroinflammation also drives the inflammation and activates the trigeminal vascular pathways. So in our case, occipital morning predominant headache refractory to migraine therapy, the phenotype of these mechanisms, the phenotype with these mechanisms can predict the occurrence of a refractory headache. So if you see the obstructive sleep apnea and morning headaches has a direct bidirectional sleep, a bidirectional relationship, sharing the same pathophysiology which I've described. However, the important point here is patients with sleep apnea headache had significantly lower minimum SpO2 and far longer time below T90 saturation than obstructive sleep apnea patients with ordinary morning headaches. So typing headache to the depth of nocturnal hypoxia. So depth of nocturnal hypoxia is significantly associated with the headache. So now, in our case, occipital morning predominant headache refractory to migraine therapy, exactly the phenotype these studies link to nocturnal hypoxemic burden. And if you see the relationship between the obstructive sleep apnea and migraine, the pooled migraine prevalence in patients with OSA is around 16%, and the risk of incident migraine in patients with OSA is double compared to the controls. Though they have bidirectional relationship, uh, what it's actually does is the worsening the obstructive sleep apnea worsens the episodes of migraine and also increases the frequency and severity of the migraine episodes. And when we treat the obstructive sleep apnea, the headache frequency comes down significantly, but and the pre-existing migraine symptoms might the headache which is worsened by obstructive sleep apnea will come down significantly after the CPAP and other modalities, and the migraine will come down in frequency as well. So, coming to the differentiating these two types of headache, like obstructive sleep apnea headache, that which we call it as a sleep apnea headache, and the migraine. As we know, both these can present an awakening, but the duration of sleep apnea headache is up to 30 minutes to 4 hours. But in case of migraine, it can go a little longer. Usually bilateral and dull, as against the unilateral and pulsating and throbbing type of headache is migraine. Associated feature, very important differentiating feature, is presence of associated features goes more in favor of a migraine, as against usually there are no associated features in patients with sleep apnea headache. Frequencies more than 15 days a month as per the ICHD3 criteria, but migraine frequency is variable, and OSA definitely increases the attack frequency. And the important differentiating point here is also the complete resolution of symptoms of headache when we use therapy like an CPAP or other modalities. Here, in patients migraine which is worsened by OSA, though the patient improves partially, migraine specific treatment is often required. And in our case, bilateral presentation, pressing, morning, unresponsive to migraine drug, and fully responsive to airway correction favors that our patient had a sleep apnea associated headache. So, how does this obstructive sleep apnea produces the erythrocytosis? As we know, the standard mechanism is chronic intermittent hypoxia, producing the gene alteration, the HIF2 alpha gene, producing increased erythropoietin and can produce erythropoiesis and reticulocytosis. But the very, very important point here is, if you see the most of the patients of obstructive sleep apnea, more than 98% of the patients do not develop clinically evident erythrocytosis despite a genuine hypoxic dry. Why does this happen? This happens because the reactive oxygen species mediated lysis of the youngest red cell, that is what we call it as pneumocytolysis. And this reactive oxygen species mediated lysis um, which happens after returning to normoxia after each apnea. The cytolysis of the newer cells happens, and that's why the erythrocytosis doesn't continue for a longer period of time to be clinically or lab becomes significant to be for the lab. And second thing is CIH, that is chronic intermittent hypoxia associated inflammation, increases the levels of hepcidin, which limits the iron for erythropoiesis. So these two factors are responsible for most of the patient of OSA not to develop secondary erythrocytosis. But when it occurs, when it occurs, it signals a more pronounced uncompensated hypoxic burden and correlates better with oxygen desaturated index than with AHI alone. So, this is a mechanism why every patient of OSA doesn't have an erythrocytosis, and presence of erythrocytosis indicates a severe degree of hypoxic burden, and which also correlates well with the headache. And this is what is the quantitative work by which is published in American Journal of Hematology, with 527 patients where OSA was studied, and it actually highlights the same point. So the high ODI, which was 19.7 rather than T19, which explains the erythrocytosis occurred in our case, and the persistent fall of hemoglobin from 17.7 to 16 to 15 in each intervention, partially and then fully correct after correcting the airway, also signifies the impact of treatment in these patients. And as we know, erythrocytosis producing hyperviscosity is not the only mechanism where the hematocrit increases more than 50% can reduce the cerebral blood flow and microvascular sludging. Along with that, it can also produce compensative vasodilation of pain sensitive cerebral vessels. This is also another mechanism how erythrocytosis it itself can produce headache in patients. So though in our patients, the obstructive sleep apnea, erythrocytosis both contributing to the mechanism of headache. And coming to oral appliance therapy, what is the role and its limit? Is basically the American Association of Sleep Medicine has recommended primary mandibular advancement devices recommended for primary snoring and mild to moderate OSA. And also patients who cannot tolerate the CPAP. Those patients will significant benefit by mandibular advancement devices. And in 2025, meta-analysis showed the custom-made mandibular advancement devices, which we have done in our patient, achieves a greater AHI reduction and better long-term adherence, because adherence and the compliance is an important feature, important problem which arises in many of the patients than which are more useful, and they have more people adhere to these custom-made devices than the ready-made devices, because the discomfort and TMJ related adverse effects are common, and usually most of these are usually transient, but it is important to really troubleshoot these patients and explain them about the using custom made mandibular advancement devices. So next, retinographia, which the surgery also is one of the way by which these patients are treated, which increases the retropalatal and hypopharyngeal airway by physically advancing the facial skeleton. A which was done in our patients, BSSO, bilateral split sagittal osteotomy. So what happens here? The prognostic indicators are the patients who are younger, patients who have lower BMI, as in case our patient has 23, and the patients who have anatomical driven phenotype rather than soft tissue obesity driven one. These patients will respond well to the mandibular advancement surgeries. So in our case, young non-obese retrograde driven matches the profile which literature associate with the best surgical outcome. That's the reason why our patient also had a significant positive outcome after the surgery. So to conclude, I would like to highlight 5 important points. One is the refractory morning headaches warrants an obstructive sleep apnea screen. OSA as a migraine mimic, even in young non-obese patients. So refractory morning predominant headache definitely requires a patient to be undergo screening for an obstructive sleep apnea. Unexplained mild erythrocytosis in young adult should prompt evaluation for chronic intermittent hypoxia after excluding the primary cause of polycythemia like JAK2 mutation. Examining the patient for retinopathy and every suspected OSA patients, because it's a distinct treatable anatomical phenotype. Oral advancement device are reasonable, reversible first step, but tolerability limits the long-term use in meaningful subset of patients. In the right, young, non-obese, retinopathy driven patient, anatomical surgical correction can resolve OSA, headache, and erythrocytosis together. Thank you.
Thank you, Dr. Datta. That was really very elegantly presented, and I loved your slides and the way you went through each aspect of the salient features of the clinical case. So congratulations, well done. I thoroughly enjoyed listening to you. And I'm sure there are questions from the audience in the chat. And let me quickly tell you that there are 3 questions that I can myself see. Not very relevant. The one question was that, was the patient overweight? If yes, did the change in BMI make any difference? The answer to that is no. You have clearly specified that the patient was not over, but did not have a BMI less than 24. And the second part of the question is, was the headache more migrainous or migraine or TTH? Again, that has been answered in that very lovely slide where you put forward the headache characteristics in migraine versus the headache characteristics of headache related to sleep apnea. So the question's been answered. Wonderful. I thought that was very nicely done. And we've already now into 8:26, so we have half an hour left for the meeting. And we all know that our second speaker for the day, Dr. Gino Johnson, is amongst us in the meeting. And uh, let us now give over the stage to Dr. Gino Johnson. So, Lata, you could unshare your slides. And Dr. Gino, the stage is all yours. Let's have a look at your case. While Dr. Gino is getting her slides on board, there is a question from Dr. Siddharth Chauhan, who's asked that is OSA a trigger for migraine? And let me take the opportunity of trying to answer that. The answer to that is yes. Patients who have migraines, there are various drivers that can be contributory to the persistence of an individual's migrainous headaches, even if they are not necessarily early morning. Sleep apnea, sleep fragmentation, large hypoxic burden, and more importantly, circadian misalignment. All of them have been implicated. And one of my residents, Dr. Archana, she did a study at Jaslok with me about 9 months to about a year ago. And this was her thesis subject. We looked at more than 50 consecutive patients who came to Jaslok with difficult to treat migraines, were treated by others. And we looked at their entire lifestyle questionnaire and a sleep questionnaire. And one of the salient things that stood out in her thesis was that a very large number of these patients, more than 60%, have often circadian misalignment as a statistically significant correlate of being associated with their difficult migraines. So various phenomenologies of sleep hygiene and sleep restorative prowess being impaired can contribute to patients' headaches. So it's a very important lesson to all neurologists. I think it's a very important lesson to all sleep people. So great. Dr. Gino's here. Gino, the stage is all yours. Take over, please.
Thank you, sir. Hope I'm audible to all of you.
It's wonderful. We can hear you.
Okay. So I am presenting the case of Dr. Kevin. He's a 37-year-old gastroenterologist from southern Kerala. He presented with a 5-year history of jerk-like movements involving the upper limb and lower limb during sleep. The history of presenting illness. The jerk was very brief, predominantly involving the left side more than the right upper limb and lower limb. And there was multiple episodes during each night. So all the episodes were similar to one another. There was no associated complex movements, abnormal behaviors, or vocalizations. When this jerking movement began, the patient was pursuing his DM, so his training involved frequent night duties and considerable stress, which all were attributing to the cause of his nocturnal jerk. So these episodes were witnessed by his wife, who was sometimes awakened by the jerking movements. However, patient remained completely unaware of these events, and he continued to sleep through all these events. There was no similar events during wakefulness. The frequency of these jerking movements had increased over the past 2 years. Even when his duty schedule was light, he was not having any night duties. He was still continued to have the events. So he was evaluated at an outside facility. So regarding his sleep history, he reported snoring for the past 7 years. The snoring was not loud and there were no witnessed apneas. His sleep was unrefreshing and he was feeling little sleepy during the day. There was no history to suggest any restless leg syndrome, sleep paralysis, sleep-related hallucination, vivid dreams, sleep talking, sleepwalking, or other abnormal sleep behaviors. Now, this was his usual sleep schedule. He would go to bed at around 10 p.m. with a sleep latency of about 1 hour. He would fall asleep by around 11 p.m. On some days, he had nocturnal awakening, after which he was able to fall asleep easily. His usual wake time is at 6 a.m. He generally do not take any naps because of his busy schedule. So his total sleep time was approximately 7 hours per day, and his preferred sleeping position was lateral. Now, his past history was unremarkable. There was no identifiable risk factors for seizures, no known comorbidities, and no significant past medical history. He was not on any regular medication and was not having any addictions. As he was from a distant location, the initial consultation was a teleconsultation, so the examination was limited. His self-reported BMI was 26 with a Friedman tongue position of grade 3. His general examination was unremarkable with no apparent focal neurological deficit. His Epworth sleepiness scale was only 4, indicating there was no significant daytime sleepiness. Now, coming to the previous evaluations, he had been evaluated at an outside facility at 2022. His baseline blood investigations were normal. In 30-minute EEG, including this period of sleep, and his MRI brain was normal. He had undergone a level 1 polysomnogram at an outside facility in 2022. However, the report was not available. He recalled being informed that it showed mild obstructive sleep apnea, and he was advised to have weight reduction for the treatment of obstructive sleep apnea. And there was no treatment initiated for the jerks or anything during this period. And after the initial polysomnogram, he had a 3 kilogram weight gain since 2022. And also his symptoms also worsened. To summarize, he is a 37-year-old male with a 7 years history of snoring, who now presented with brief jerking movement of upper limb and lower limb exclusively during sleep, of which he is unaware, but which are witnessed by his wife. His sleep is also unrefreshing. His previous EEG and MRI brain were normal, while PSG reportedly showed mild obstructive sleep apnea. He has gained approximately 3 kg of weight since the previous evaluation, and also his symptoms worsened since last 2 years. So as his previous neurological evaluation was unremarkable, with a normal EEG and MRI brain, a sleep-related movement disorder was strongly considered. So our hypothesis was, given his previous history of mild obstructive sleep apnea and subsequent weight gain, so we thought that his obstructive sleep apnea may have been worsened, resulting in respiratory events and arousals during sleep, which could have associated with arousal-related myoclonic jerks during his sleep. Therefore, we proceeded with a level 1 polysomnogram with expanded EEG and EMG monitoring to evaluate for sleep-related movement disorder and also to exclude the nocturnal seizures. So the additional EMG electrodes were placed over bilateral deltoid muscle based on the movement demonstrated by the patient and over the bilateral anterior tibialis muscle for the lower limb movement. So after the polysomnogram, the morning after PSG, the patient reported that his sleep during the sleep study was slightly more disturbed than usual sleep. As expected, he was unaware of any nocturnal jerking movements, and the sleep technologist observed a very brief jerky movement during the sleep onset. But she told that there was no further episodes or events which was noted during the study. So the polysomnogram was scored as usual, initially with sleep staging and arousal, which was performed first. And when we look at the sleep architecture, we can see that he only slept for 280 minutes. And also the arousal index was elevated. It was 33.6. Then we went to score the respiratory events. He was pretty snoring loud, and his AHI was 9.2 events per hour, which was consistent with mild obstructive sleep apnea. There was no significant oxygen desaturation with an SpO2 nadir of 92%. So when we started scoring the limb movements, we noticed that he was having very frequent limb movements. So we can see this is a 5-minute recording, and we can see there is multiple limb movements. So all these blue signals we see are limb movements. And he was having, when we look, he was having limb movement approximately every 30 seconds. So this is the limb movement data. His periodic limb movement index was elevated. It was 64.5. So we all know in adult APLM index more than 15 per hour is considered elevated. And he was having a PLM arousal index of 22.7 per hour. So this led to a slight change in our hypothesis. So patient may have had arousal related myoclonic jerk with the arousal potentially resulting from either respiratory events or frequent periodic lung movements he was having. So when we look at the arousal data, arousal summary, he was having about 157 arousals in total during the night of PSG. Of this, 106 arousals were related to periodic limb movements and 41 was related to apneas and hypopneas. So the arousals was more because of the periodic limb movement rather than the respiratory events. So we then reviewed all the epochs again and we focused on each epoch with individual like EMG burst in the upper limb. So this was the 5-minute window we showed last time. And what we did was whenever there is a signal in the upper limb, we played the video. So there was so many epochs with these signals to know that whether any of this was jerking movements that was disturbing the patient. So after reviewing the study, we identified 9 epochs with subtle jerking movements. And all these events were occurring in the N2 sleep. So this is a video. And here we can just look at the foot, the lower limb that will be showing the limb movement and the jerking movement in the upper limb. Yeah, so the jerk is really subtle. So this is another epoch showing similar jerking movement. This also shows the same pattern with a limb movement in the lower limb followed by the jerking movement in the upper limb. Okay, so this shows the movement data. So there was a total of 9 brief myoclonic jerks involving the proximal upper limb. Of this, the first occurred during the wake to sleep transition consistent with the hypnic jerk, while the remaining jerks occurred following the lower limb movement of these periodic limb movements. So an overnight video EEG recording was also performed along with the polysomnogram, which was normal with no epileptiform discharges associated with the jerking movements. So the final diagnosis was benign sleep myoclonus associated with periodic limb movement related arousals along with periodic limb movement disorder and mild obstructive sleep apnea. As the patient had periodic limb movement disorder, we evaluated the iron status because iron deficiency in brain is one of the suggested mechanism for periodic limb movement disorder. But his serum ferritin and transferrin saturation were within normal limits. So this patient had 3 potential treatable sleep conditions. One is benign sleep-related myoclonus, periodic limb movement disorder, and mild obstructive sleep apnea. So when we look at the periodic limb movement, benign sleep-related myoclonus, usually that does not need any treatment unless it significantly disrupts the patient's sleep or the bed partner's sleep. And whenever we need a treatment, usually clonazepam is the most common medication that is used for the symptomatic treatment. This patient also had periodic limb movement disorder, which was contributing to his free sleep fragmentation and myoclonic movements. So periodic limb movement disorders, we usually treat with either alpha-2 delta ligands such as gabapentin or pregabalin. and with dopamine agonists such as pramipexole and ropinirole. Although clonazepam is not a first-line treatment, but they are also being used off-label for the symptomatic benefit. As the patient was having obstructive sleep apnea, we avoided clonazepam because of its potential to worsen the sleep disordered breathing. Okay, so after removing the clonazepam, we have both the alpha 2 delta ligands and dopamine agonist that can reduce the periodic limb movement. However, this alpha 2 delta ligands category, they have an additional advantage over this dopamine agonist, that they can improve the sleep continuity and they can reduce the free sleep fragmentation and arousal. So as the patient's presenting symptom of jerk is more due because of the arousals and sleep fragmentation that he is having because of the periodic limb movement, we decided to start him on an alpha 2 delta ligand, and we picked gabapentin. So the next issue he was having was his mild obstructive sleep apnea. So this brings an important question, like should we treat every patient with mild obstructive sleep apnea? So let us see what the evidence tells us about the benefit of treating obstructive sleep apnea. So it reduces the cardiovascular risk in moderate to severe obstructive sleep apnea, and it also improves the daytime sleepiness and quality of life in patients with mild, moderate, and severe OSA. So, in nutshell, all patients with moderate to severe OSA, that is AHI more than 15, should be treated regardless of the symptom. And for mild OSA, that is up to 15 AHI, treatment is recommended if the patient is symptomatic or if he has a comorbidity such as hypertension. So in our patient, because the obstructive sleep apnea was mild and there is no significant oxygen desaturation, or he was not having any comorbidity, we decided not to initiate PAP therapy at this stage. So this was the management we offered. We targeted the periodic limb movement initially, which was causing the myoclonic jerk by his arousals. So we started patient with gabapentin at a low dose of 100 milligram, and we asked the patient to take it at 8 o'clock at night. And we also plan to consider OSA treatment later if his sleep remained unrefreshed despite the treatment of periodic limb movements. So at 1 month of follow-up on gabapentin 100 milligram, so this was his status, like he could sleep fast. His sleep latency reduced from 1 hour to 30 minutes. Then his sleep became more refreshing and his daytime sleepiness also improved. The conclusions: the periodic limb movements may be missed even with a thorough sleep history and can cause significant sleep fragmentation and arousal. Therefore, periodic limb movement disorder should be considered in the differential diagnosis of any unexplained sleep complaints. And also a systematic scoring of polysomnogram with the sleep staging, arousals, respiratory events, and limb movements can reveal the cause of unexplained nocturnal events. Thank you.
So Dr. Manveer Bhatia, this.
Yeah, hi. So
Right.
that was a really nice case, Dr. Jinu. And I think, especially for neurologists, it's of really great relevance because to see any abnormal movement or an involuntary movement is first step people consider it as epilepsy. So I think she's highlighted that beautifully, that not all movements are epilepsy. Second, I think she's also highlighted the importance and significance of mild OSA. Should all OSAs be treated? And third, of course, that how to manage these patients so that they have a good night and a good day. Now it's open for questions. If people want, we can then take them one by one.
So I had a question for Gino, Dr. Bhatia.
Yes, sure.
So, Gino, lovely case. I noticed in your slide that, in the sleep fractionation in the first slide that you showed. Uh, his N3 only was very little.
Yes, sir. Actually, his sleep was super fragmented. He used to wake up, he used to stay awake
Point,
10,
I
15.
read 0.9% and
Yeah,
I read
exactly, sir.
REM sleep as 6.4%.
Exactly, sir. He was waking up and staying awake for maybe 10, 15, 20 minutes and then sleeping back for some time like that. Actually, it was not a good, like continuous sleep. He was
quality
sleeping.
sleep at all.
Yeah.
Right.
Only
Another
thing we could get something from that study
I
rather than,
think
yeah.
the other thing you can maybe highlight a bit for people who are attending the relationship of PLMD with RLS, if you can shed some light on that. So
Yeah.
this
Yeah.
patient had no symptoms of RLS.
Yeah, actually, I even after reading the
Hmm.
PSG, I again called him and repeatedly asked like whether you have any discomfort. So he told definitely he was telling no.
Okay.
So there
So
was
what percentage of people will have those with RLS will have PLMD?
so it is very high. Exactly, I'm not sure the percentage because like RLS, most of the patient, or maybe I think more than 90, almost all patients with RLS, we used to see periodic limb in sleep. But usually the limb movements in RLS is not causing arousals.
No, not really. I don't think so. But what about isolated PLM? How often are those?
In
For people
patients.
like your case, so who don't have RLS at all.
Yeah, so, ma'am, I am not sure about the percentage.
I think that's very less. It's only about 10,
Yeah,
15%.
So Dr.
So,
Bhatia, I wanted to ask you that,
uh,
this lack of deep sleep and the very
hmm,
short period of REM, would you kind of consider magnesium or melatonin for such patients or?
I would actually do what she's done, give gabapentin first
Mhm.
and see what he's doing and how is his night and day. Melatonin, I'm not very sure. Magnesium, maybe we can do because magnesium works in both ways. But again, I recently reviewed this magnesium whole thing, glycinate, for a little while.
Mm.
It's theoretically it works, and I think some people are feeling better with it. Let's put it like this. There's not much evidence, but I think individual cases are beginning to say that they are feeling better. Let's put, simply like that.
So
Evidence wise,
one
I
of
don't
my,
think.
yeah, one of the things I understood about REM cycling is that MT1 and MT2 receptors are important contributors to initiating the REM switch to drop.
Hmm,
And therefore, people with very short REM, if of course you treat the underlying disease, you treat the periodic leg
yeah,
movement.
yeah.
But I was wondering whether there is some role of
But
melatonin here.
no, magnesium might help the PLMs for all you know.
Yeah.
We don't know. There's somebody asked a question about a genetic predisposition. So genetic predisposition is very high, or let's say there is a familial RLS variety. I'm
yeah.
actually that's an important thing. I'm not sure about a familial PLMD variety.
PLMD is usually less studied. Most of the PLM, all the maybe datas are linked with the RLS. So there is nothing we could, if I couldn't find anything like PLM is genetic or something like that. But all the datas we have is linked to the RLS data, not exactly PLM alone.
Yeah. Forums about whether PLM should be treated or not.
See,
So that was also going on in multiple conferences.
yeah.
But of course, if it interrupts the sleep, it causes fragmentation, causes arousals, and the other thought is that it is also again causing sympathetic activation.
Yes,
That's why maybe it should be treated.
should be treated. Yeah, and I think Gino showed very elegantly that the arousal index was
Yeah.
elevated in her
Yeah.
side. So many of the periodic leg movements were associated with arousals. So that would also warrant therapy.
Yeah, somebody has put this question. This was asked earlier also once before that can a PAP titration result in worsening of PLMs? Because in sometimes it's been seen in the split night studies that the beginning part doesn't have the PLMs and the after the titration it does. So there was a hypothesis to it. Are you aware of that hypothesis as to why this is seen? Yeah, Joy. There was some discussion. I attended some session which they did give a hypothesis as to why the PLMs appear after a titration.
So one of the things that I think we as neurologists need to understand is that the split night studies are done for convenience. especially when you suspect that the person has overtly very severe sleep apnea, to shorten
Yeah.
the evaluation process. But it disallows assessing what's happening in REM sleep, because in the latter half, you are papping the patient. So any kind of data that emerges from split studies is difficult to interpret, because in the first 3 cycles of sleep, REM periods are very, very brief. And not sure how valid one could hold that. But I must today.
There was I'm in which this thing was discussed in great detail. I can't get the answer.
Yeah. But today was very, very good. I think thoroughly enjoyed both the cases. They were nice, very elegantly presented, and very elegantly discussed as well.
And very clear message.
Absolutely.
Very nice.
Very
Yes. So
nice. Yeah.
to neurological problems which can be seen. Sure, very nice. Any more other questions? Otherwise, then we will close this and thank everyone for being here with us, and also the organizers and the back end digital team for coordinating everything.
There have been 50 participants in this webinar.
I think we had about 60 at one time. There were 60, 62. So I think that's a good way. Just to announce for the ones who are here that we have a workshop at the IAN on the 28th of October, Jaipur, which is a polysomnography workshop. And we are just going to start circulating the information. So people who are interested, it will be a good opportunity to learn some more about reporting and PAP. And we're going to try and make it hands-on so that you can get some feel of looking at the data just for information. You will get some more announcements soon, but
wonderful.
With all the senior faculty. Yes. Okay. Sure.
Wonderful. Great. I'm glad you brought it up here. We can put it on the group also.
Yeah. I'll just, actually, that just while I'm talking to you, Bhavesh has just finalized the brochure. So I'll just send it off.
Wonderful.
Yeah. Thank you, everyone, again. And thank you.
Great. Thank you, everybody. And thank you, both speakers, for taking your time out and making such lovely slides for all of us to participate. Thank you very much.
Thank you.
Good night. Thank you. So Joy will announce the next one soon. Okay.
Yes. We will do one. We will do one in early October, before the meetings kick off. So
okay, sure.
We'll do one in early October. Yeah.
Okay. Bye.
Great.
Good night.